Hello, and welcome to our live stream on supporting children and teens who have anxiety and/or obsessive compulsive disorder, or OCD. It's part of our month-long effort to celebrate Mental Health Awareness Month, and we're so glad you've taken the time to join us live or via recording. I'm Kara Gavin with the Michigan Medicine Department of Communication. Today, we hope to provide information to help you and your family navigate conditions that are increasingly common in young people and understand what treatment options are available. We're so fortunate today to have three University of Michigan experts who can help us understand what we know and don't know about why anxiety and OCD happen in kids and teens, what signs and symptoms parents and others can look for, what kinds of therapies and medications can work, and how both kids and parents can use coping strategies in everyday life. All three of our panelists are faculty in the Medical School Department of Psychiatry. First, Dr. Emily Billick is a clinical psychologist and a clinical associate professor with U of M's Child OCD and Anxiety Disorders program, and a specialist in both treating and studying these conditions, as well as training the next generation of providers. Next, Dr. Morgan Boland, who is also a clinical psychologist and a clinical assistant professor with U of M's Child OCD and Anxiety Disorders program. And she's also co-facilitates our parent management training and comprehensive behavioral intervention for tics clinics that we offer. And lastly, Dr. Joanna Quigley, a child and adolescent psychiatrist who's an associate professor of both psychiatry and pediatrics. She serves as the associate medical director of our ambulatory child and adolescent psychiatry clinics and our adolescent addiction treatment services. Thank you, all three of you, for joining us. And thanks to the University of Michigan Alumni Association and CS Mott Children's Hospital for supporting this live stream. Before we start, a few housekeeping items. If you're watching this live, you can submit questions at any time, and we'll pick some to be asked during today's chat. Questions can be submitted by commenting on this video on whatever platform you're watching on, but please note that your name or your profile name will be visible to others who are participating. If you prefer a more anonymous option, you can send a private message to us through the Facebook direct message function on the Michigan Medicine Facebook page. We know that there may be many questions, so we will likely combine some of them on the same topic. And please know our experts can't give specific advice for an individual situation that you might be facing. If you can't stay for the whole chat or you want to share the recording with a friend, you'll be able to watch after the live stream ends through the Michigan Medicine YouTube channel. So let's start with a very general question that perhaps each of you could answer in turn, and which is that all children and teens and adults can sometimes feel anxious or nervous about something they need to do, somewhere they need to go, some types of interactions or situations they're going to be in. What's the difference between that kind of anxiety and a diagnosable anxiety disorder? Who'd like to start with that one?
I'm happy to go first. Yeah, it's a great question. As you said, Kara, everyone experiences anxiety from time to time. It's very normal to see your child, your teen experience nervousness. And in fact, it's important, right? We have to feel fear. It helps keep us safe from things that are truly dangerous. And sometimes a little bit of anxiety can remind us what's important to us. And, you know, if we have a test coming up and I feel a little anxious, it might really remind me this is important to me. I'm going to study a little harder. Where does it cross that line between normal or even helpful anxiety to something that might be considered clinically impairing? For me, what I usually focus on is that second word there, impairment. When does it start to become a problem in the child's life or in the life of the people around them? Is your child missing school? Are they missing out on activities they would enjoy? Are they so stressed that they are, you know, things they used to enjoy are not fun anymore? And as I mentioned, sometimes that impairment can even happen outside of them. Are they always late? And so you are running late to work, or are you having to pick them up from school? Things like that are when, doesn't mean that they necessarily have a clinical anxiety disorder, but that's when I would be more concerned and starting to think, like, should I go see my pediatrician or should I ask the school social worker and learn a little bit more about what's going on?
Great. Would either of the others like to jump in at all, or should we keep going with this next question?
I think the other thing I would add would be that anxiety can show up in our lives in different ways at different times. And so when a child is younger, that maybe they struggled a little bit with, say, drop off at childcare, or a little bit of separation anxiety that never got to be too significant. But, maybe when they're 11, 12, 13, anxiety might show up more in social situations or with more generalized worry that actually grows into a bigger problem. So, development is dynamic, and the way these things show up over time can change. So that would be the other thing I would mention in parallel with what Dr. Billick was saying about impairment, that we might not think it's going on because we didn't see it show up a certain way, typically for our child or for someone in our lives, and then it shows up quite differently and we're caught a little bit off guard. So that's not unusual.
Dr. Bowen, anything to add?
I think just expanding on what Dr. Billick mentioned with the functioning, in my work with patients, my main goal is to never let anxiety prevent them from living the kind of life that they want to live and doing the things that they want to be doing. And when we start to see that anxiety is prolonged and intense, and we start not being able to do the things that we normally do or that we want to be doing, that's when we start to become more concerned.
Thank you all. We also included OCD, or obsessive compulsive disorder, in the event title. So can someone tell us a little bit more about OCD and how it fits into the anxiety disorder picture?
I'd be happy to answer that question. So OCD, or obsessive compulsive disorder, is a type of anxiety disorder. It's characterized by intrusive thoughts or obsessions that are alleviated by compulsions or some method to get rid of the distress. Inherent in any anxiety disorder is kind of a distressing feeling and some form of escape and avoidance of that feeling. So OCD kind of aligns with that as well.
So they're behaviors that they're doing in order to make themselves feel better, basically. Is that how you put it?
Yes, to alleviate that anxiety or that distress.
So with both of these, or this spectrum of conditions, I guess we could say, what should parents, caregivers, teachers, grandparents be on the lookout for? And are there things that children and teens can do to mask this anxiety, or how they're coping with it? Or are there things that are easier to notice? We've talked about some of the things about being picked up early at school, things like that. But can we elaborate more on what to look for?
I can jump in. Yeah. It looks so different for every kid. So I don't want to say that this is the only way it can present, but some things to be on the lookout for are just a change in functioning, right? So especially if you are wondering, has something changed? Is my child developing anxiety? You want to look for a dramatic change in the amount that they are engaged. As Dr. Boland said, when we're talking about anxiety disorders or OCD, a hallmark feature is avoidance. And avoidance can also look a million different ways. It can be very obvious. It can be, a young kid crying and saying, no, I don't want to go to the birthday party. I'm scared, right? That we can maybe say, oh yeah, that's clearly anxious avoidance. But it can also look really subtle in different ways. So it could be things like, oh no, I don't want to spend time with other kids because I just don't like that kind of thing, where in the past that's something they enjoyed. That's not a diagnosis. That doesn't mean that they have anxiety, but it would be something that I would keep my eye on if that's a change in functioning for them. And sometimes avoidance can be I would say even more subtle, where what the child or the teen is avoiding is the anxiety, not a specific place or a specific thing. So ways that we might avoid anxiety might be to ask a lot of questions, right? Sometimes we talk about this with anxious kids. You see a lot of reassurance seeking. It could look like a lot of different things, like, is this expired? Is this food I'm about to eat expired? Or will I be safe if I go to school today, right? Those type of questions, they are avoiding feeling the anxiety. So that's the thing I'm on the lookout for. And sometimes it can be really obvious and sometimes it can be subtle. So I know that that's tricky for parents. But the main advice would be to look out for a dramatic change in functioning.
I think we'll also see irritability. So you might see mood changes that are hard to figure out. And then when you're able to take some time to kind of distill down patterns or triggers, it can help highlight what might be actually driven by anxiety and maybe that avoidance and maybe, feeling a lot of distress, but not knowing how to express that or articulate it. So it comes out as moodiness or irritability. Additionally, what I often see is maybe during the adolescent years, patients showing up with a concern about, say, a mood issue or even ADHD. So they come in and say, I think I'm really struggling with school and I'm not doing as well as I used to do. I think I have ADHD. And it's great that a lot more is discussed in social media and online about mental illness or mental disorders, and people talk about their own experiences with something like ADHD. But sometimes a family might show up with that as being in their mind as the obvious thing that's going on. But when we peel back the layers, there's actually a tremendous amount of anxiety occurring for that child, a lot of intrusive worries that are really impairing their ability to focus and learn. And so that's why it can be tricky to figure out, what is the chicken and what's the egg in some situations. But, again, it's something to just think about and reflect on when you notice that change. It's like what else might be going on or what else might be missing. And I would be remiss in not talking about adolescent substance use when you ask this question, because just like grownups, adolescents who maybe struggle with social anxiety or other types of anxiety may find using substances alleviates that initial anxiety they feel when trying to join a social setting or get involved with a group or feel comfortable when they're out with their friends. And for somebody who is particularly primed for a use disorder, that can be a really slippery slope for them where they then only feel comfortable when they're using and that use escalates and then gets out of control. So we're always looking at, what is the underlying set of feelings like Dr. Boll and Dr. Billick were talking about that's creating that distress, because that helps us understand how to take next steps with treatment.
And just to be clear, thank you for that and bringing up substance. We're talking about drugs and alcohol, so cannabis, alcohol, even nicotine. Would you include that in that as well?
I definitely would include nicotine in that. Definitely, a lot of kids will describe feeling an initial relief of their anxiety when they use nicotine in whatever format.
Thank you so much. So I think we've talked about the signs, things that people can be looking for. So what is the first step, and what should they do if they're concerned that their child or a young person in their life may be dealing with more than just normal garden variety worry?
I think the first step is addressing it and talking to your child or adolescent about what is going on, approaching the situation and saying, I'm noticing these things. What do you think about this? How do you feel about this? And kind of like evaluating their insight and their concern. There's really great treatment available for anxiety and OCD. And, maybe after having that initial conversation, considering reaching out to a professional for some evidence-based intervention to address symptoms.
So really speaking up, expressing those concerns, and maybe at least having on the person, the child's medical record at the pediatrician or family medicine doctor's office. Is that sort of the place to start? And that way, at least there's somebody monitoring for it. And maybe there are things that pediatricians and family medicine docs can do as sort of standardized questionnaires, at least in that office setting at a well child visit, right? So even if they're just going to start monitoring for it, great. So let's talk about some of the roots of this. Like, what do we know about why someone could be prone to anxiety or OCD? And are there, genetic factors? Is it life events, other factors? And I think, Dr. Billick, I think you might want to take this one first, and then the others could jump in.
Yeah, absolutely. Yeah, I think it's always like a pressing question when you see your child struggling, is to wonder, like, what caused this? Was it my fault? And as a parent myself, I am not immune to that, just those late nights where you're thinking, did I do, is this all my fault? So, I mean, the first thing I say is no, it's never any one cause, right? And unfortunately or fortunately, we're not really ever able to pinpoint and say, this is what it is. It's different in that way than something like PTSD, where you're like, this event probably was the impetus for what came next. With anxiety, often there are genetic factors that make us predisposed to interpreting the world as threatening or to interpreting certain things as threatening, right? That's what I think of when I think of anxiety. And certainly a family history of anxiety or OCD, even depression, can make us more vulnerable to having anxiety, OCD, or depression ourselves. And that doesn't mean that every child of a person who has those concerns will have it either. Certainly, there are life events that make a difference, right? There can be, in terms of parenting strategies, like some children really need a lot of hands-on support to get through the world safely. You can think of those children who are risk takers, who are, jumping off your coffee table before they're really walking. Yeah, you may need to have a heavier hand in protecting them. And some of our kids who are a little bit more vulnerable to anxiety can interpret some of that as like the world is not safe, right? So this is all to say it's no one's fault if someone has anxiety, and there are so many things that we can do to help. And parenting work or caregiver work can be a big part of treatment. I know we'll talk about treatment later, but just because we didn't cause it as parents doesn't mean there isn't anything we can do to help make it better. So yeah, I think that's what I would say.
Great, thanks so much. Dr. Boland, Dr. Quigley, anything to add about the origins or what we've learned over time? Or can we actually see what's going on in the brain of someone who's having a panic attack or anxiety over a certain thing, or is focused on the action that's the focus of their OCD? Can we see that in brain scans?
I can let my colleagues answer that as well. I would say that we're not at a stage where we can put you through a scanner and say, oh yeah, this this is the type of anxiety and why it's happening. But those scientists and clinicians who study neuroimaging and the brain and anxiety disorders have developed some pretty sophisticated levels of understanding in terms of knowing which parts of the brain may be overactive or more robust for somebody who deals with more anxiety, and how we understand all of those connections between different parts of the brain that might reinforce that experience for somebody or be potential targets of treatment over time. So I would say generally it's a really exciting part of our field of understanding, but we're not quite at that screening with imaging or diagnosing with imaging standpoint yet.
And I'll just add to that, Joanna, that reminded me, I once had a student ask me, in a research study, why we didn't just use a blood test for depression. And so it's a reminder that actually, in many ways, our diagnostic tools for all mental health disorders, and especially things like anxiety and OCD, they do rely on self-report or, caregiver report. We don't have that level of specificity with neuroimaging, right? We can see brain regions that may be lighting up, so to speak, when an individual has anxiety or OCD or depression. Usually it's not super specific. And sometimes the findings are contradictory and very confusing. So I think it's sort of like the next frontier. There's going to be, I hope, a lot of really interesting work that will come out that help us understand the brain and our anxiety and OCD a lot better. But the same thing holds true for things like blood tests. We don't have markers like that right now, and I don't know if or when we will.
Right, or genetic tests that can measure things. But then also there's this aspect of, you talked about self-report and what someone is feeling and experiencing in their mind, but there's also a physical aspect to anxiety. So could some of you talk about what physical symptoms kids or teens might be reporting? Do we know why that happens? And also, can that be something that is kind of an entry point to talking about what's going on in their mind because of something that's happening physically on a repeated basis?
I can speak to some of this, Karen, would also mention kind of an additional point from one of the prior questions is that we also think about trauma when we think about causes of anxiety, and I didn't want to leave that out. it does tie in with some of the physical manifestations for someone. So if they have experienced a certain type of trauma, their physical experience when their anxiety worsens might be associated with that part of their body or physical sensation. But some of the more typical complaints we might hear from a child who's dealing with anxiety are, tummy pain or feeling like they've got lots of belly aches. And we know part of the reason that might happen has to do with the fact that there's such a heavy connection between the brain and the gut. And that could be a whole other talk, right? But belly pain, belly aches, nausea can also be associated with anxiety. People do describe panic attacks, and kids might describe them this way too, of feeling like your heart is racing, or you feel really sweaty all of a sudden, or maybe you even feel almost faint. Kids will also tell us about, headaches or just body aches. So pain can be part of a kid's presentation when they're dealing with anxiety. And tied into the physical symptoms is also changes in sleep. So if a child is really struggling with anxiety, you might see them start to struggle a lot with falling asleep. Their intrusive worries and thoughts might be really on fire at nighttime because they're lying in their bed, they don't have any other activity to distract them, and it's really hard for them to just sort of shut down those worries at nighttime. But we can also see disrupted sleep with anxiety. So they might be waking up more frequently throughout the nighttime, regardless of whether they tell you they're having nightmares, and just might be experiencing, poorer quality of their sleep. When we talk about tests that you can do, one question I'll get is, well, should we just test for thyroid disease, and should we do a whole bunch of lab tests and make sure nothing else is causing it? And we want to be really careful with just doing tests for the sake of doing tests. We always want to look back at family history. What are the other physical symptoms that we might be looking at, and then working out whether a test really makes sense. And I'll let Dr. Billick and Dr. Morgan Boland chime too.
Yeah, I think the only thing I'll add is anxiety can be and often is a very physical experience. We educate patients on the fight or flight response and why these changes are occurring in our bodies. And understanding why this is happening in our bodies can really go a long way in treatment. And part of the intervention is teaching patients how to manage these physical sensations.
Excellent. Thank you so much. And I really quickly, a lot of us have heard that anxiety in general is on the rise, that there's more kids being diagnosed, and similarly around school avoidance, whether or not it's specifically linked to anxiety. So Dr. Billick, I think you wanted to maybe address this idea of what trends we're seeing right now and what might be contributing to it.
Yeah, it's a good point. I mean, certainly we have seen anxiety be on the rise in young people for a while now. And I would say that the COVID pandemic certainly exacerbated that. And we saw a huge increase in youth coming to, to our doorstep here at the clinic. And I think nationally, the Surgeon General talked about a youth mental health crisis coming out of COVID. And I think things are a tiny bit better than they were at the height of it, but they are not, back to baseline, which was already pretty high, right? We know that a lot of kids struggle with anxiety. And I don't know the exact statistics for today, but certainly I've read before that by age 18, about, a third of kids will have a diagnosable anxiety disorder. So, and that might be outdated. What is causing it? What's causing the rise in anxiety? And that's sort of the $1 million question right now. And a lot of people are writing books about it. So you might have read about Dr. Haight's work on, the anxiety crisis in youth. So a lot of people are theorizing different things, like, is social media to blame? And that's something we hear about a lot. I think that there is probably a role that social media plays in exacerbating mental health concerns. I don't know about you, but I know if I spend a lot of time on my phone, I don't feel great. So it seems very plausible to me that it can play a role. I would just be cautious against assuming that's the whole story. I think there are a lot of other things that are going on or have gone on, both potentially good, such as increase in screening, which can make levels of things like anxiety look like they are artificially raised when we screen better for it. Mental health awareness, reductions in stigma, all those things can lead to people feeling more comfortable coming forward with the concerns they're having. So there are some potentially good reasons why we see the rates going up. And then there are some other ones, like a lot of students these days struggle with a lot of existential fears about the climate, about the political situation, about the economy, what they're going to do after they graduate. And those are big, heavy things for any of us to be grappling with, and certainly could be contributing to anxiety for youth. So those are just some of my hot takes on what might be contributing to it, but I'd be interested what my colleagues think as well.
Yeah, Dr. Billick, you kind of hit every single point that I was thinking. I think too, there's a lot of great research and interventions coming out about increasing independence in children. And that with COVID and today's society, there's just less opportunities for independence. And we know that when we give our children opportunities to become more independent and face some challenges, that they build some really good skills and become more resilient. And I really kind of like this research around independence, and it's something that I incorporate into my work. And I do think that that potentially is a piece that could be contributing to this, is missed opportunities for independence.
That's really interesting. Thank you so much. I want to talk a little bit about OCD, and we're getting some audience questions about that. Are there things that, does someone with OCD always feel distress and release, or do they, understand what's driving their compulsions or their actions, and do they always want to change? We had somebody actually write in and says that their child, maybe doesn't feel distressed from what's driving them to do a compulsive behavior. But so talk a little bit more about what we understand about OCD specifically.
I can jump in. OCD is complex, and I think of it like snowflakes. There's a different presentation for OCD for every person who has it. So it's hard to make a lot of generalizations. I will say that no, not everyone wants to work on it for a lot of different reasons, because OCD is sort of characterized by intrusive thoughts or images that are very scary or uncomfortable for the individual, and the behavior they do to make that go away. And depending on your level of insight as someone struggling with that, you may know that that's what's going on for you, or you may only know that like doing this one thing makes me feel better. I think that what can make it really hard is that compulsions may be something that makes their life better, but makes things very hard on the people and the world around them. I hear a lot of times about families who are going through, 5 dish soaps a day and, rolls and rolls and rolls of toilet paper. And it's not only a logistical nightmare, it's just a financial burden for the family. And that's for contamination. Certainly, that's not the only presentation of OCD. I think what we find is that sometimes youth are not really interested in working on it because they're smart enough to know that a big part of, at least of the psychotherapy of getting through it, is that they have to face their fear a little bit. And that can be, the extents that you see people with OCD going to avoid or to feel better from their intrusive thoughts and obsessions, that it can be a real deal breaker to think about that. The only other thing I'll say on this is, I would never make a diagnosis with this limited information. The thing is that sometimes the word obsession is used in so many different ways in our culture that it can be misleading what OCD is. And so kids who have a really strong interest and enjoyment of a certain task, that can look like an obsession when it's not really what we mean in terms of OCD. It may be impairing in a lot of different ways, but if they're doing it because they really enjoy it, I would probably be thinking of some other concerns before I was thinking about OCD.
Thank you so much. So going on to our next question, we've talked a lot about what these conditions are, how they make themselves known. Let's get into the treatment picture. And I think actually, Dr. Billick, you just alluded to something that I think is common in treatment of anxiety disorders and OCD, which is exposure therapy. So maybe you could keep going and talk about what that is and how does it work, and what do we know about why it works?
Yeah, I'll start and then I'll pass it to Dr. Boland, who knows a ton about this. So exposure therapy is a fancy way I think of as referring to facing your fears. And really, I think about it as systematically approaching fears in order to overcome problematic avoidance, right? So avoidance that's getting in the way that we talked about before. And we have a lot of both theories and science to show why we think it works. But the simplest way that I like to think about it is it's new learning. If I am afraid of dogs and I avoid dogs, I never get the chance to learn that being around dogs is safe. And probably every time I avoid the dog, I'm reinforcing this belief that, yeah, I would not have been safe if I approached the dog instead. And so by approaching fears that are safe or are reasonably safe, we get the chance to learn something new. And over time, that rewires our brain, so to speak, to allow us to not be so afraid or to at least let us do it with the fear. But Dr. Boland, I would love to hear from you as well.
Yeah, adding on to what Dr. Billick mentioned, we work with patients and develop a plan to break their fears down into very small, manageable pieces. And we collaborate. It's really a team effort. Oftentimes we include the parents. I always emphasize the child or adolescent is in complete charge of the treatment and the pacing. But we work to break their fears down into these small, manageable steps, and we practice systematically facing them. And through this process, we can develop kind of more helpful and adaptive thinking around the feared situation or stimuli. We often see that the things that feel like impossible and that are way too hard suddenly become manageable or easier, or at least conceivable, that it's something that they can do. But inherent in exposure and response prevention, sometimes you might hear it called ERP, is just working with the patient to help them realize that they're capable of this. They're capable of facing their fears. They're capable of changing their thinking around this. And there's so much more that they can do than they're probably giving themselves credit for. The other components, we kind of touched on this briefly, is learning to kind of manage some of these physical sensations around anxiety, working with parents to manage the parental role and potentially maintaining the anxiety, and then again, kind of addressing some unhelpful cognitions around the fear or anxiety.
So that gets into things that we think of as talk therapy, right? Sessions where you're building on your previous sessions. And so is that a kind of talk therapy that's specific to anxiety, or is it sort of related to what's done for depression?
Yes, it's rooted in cognitive behavioral therapy. So I think of exposure and response prevention as kind of like this subset of ERP where we address the triangle. So the cognitions, the physical sensations, and the behaviors.
Excellent. Let's talk about medications, and I think Dr. Quigley was going to address this. So I know that parents might be hesitant to go this route. So Dr. Quigley, can you talk about the role of anti-anxiety medications in kids and teens, safety, how to find one that works, and whether this is something that someone's going to take long-term, or can they eventually come off of it? So Dr. Quigley.
Yeah, so I will try and answer all of those questions. So, really the psychotherapy and the work that Dr. Boland and Dr. Billick are talking about is paramount. So that's the cornerstone of treatment. And then we think about medications as being, added on to that or supplementary. And we think about that as a way of helping treatment, be more effective over time. So I like to think about it as maybe helping a person turn down the volume on the intensity of their symptoms so that it's less overwhelming to get through that ERP, course of treatment. So generally speaking, just as in adults and kids, the main sort of daily medicine that we would talk about using for anxiety disorders and for OCD would be the selective serotonin reuptake inhibitors. So those are medicines like sertraline, also known as Zoloft, or fluoxetine, also known as Prozac, escitalopram, known as Lexapro, and citalopram, known as Celexa, to give you some examples. Also in obsessive compulsive disorder, you might see someone use an older medicine called fluvoxamine, which is Luvox, which is still a cousin within that family, or clomipramine, which is in a slightly different family, but has been used for a long, long time. So the way we think about using those medicines is, starting at a very low dose to assess for tolerability, and then slowly advancing that dose over time, and then getting to a dose that works. So sometimes the worry is about starting medication at all, and we're going to talk about things like side effects, which might be a period of time when your child deals with a little bit of tummy upset or headache, or maybe feels a little bit tired. Those things ideally go away over time. And then the other worry can be, well, are they going to be on too much medicine? But we do want to get to a good dose of medicine if you're going to bother taking a medication at all. So it can take a lot, quite a bit of time, maybe several months, to get to a dose that's really more helpful. And that might be your maintenance dose for a period of time. And then maybe something happens, or your anxiety gets a little bit worse, or therapy is getting harder again. And then you might have to shift that dose up. Generally, in anxiety disorders, but especially OCD, we are using higher doses of these medicines than we use to, say, target depression, if we're talking about sort of bread and butter comparisons of treatment. In terms of how long we stay on the medicine, our general recommendation is that you're at that maintenance dose, so the dose of medicine that worked for your kid, for at least 9 to 12 months. And we want to give that amount of time for you to really help your work in therapy go well and achieve some remission of your symptoms. If you come on and off your medicine too quickly, you're not going to maintain that benefit. Many people will decide, you know what, this is really helpful to me. I'm doing well. I just don't want to stop my medicine. And these are generally safe medicines to stay on for a long period of time. And a lot of my anticipatory guidance around it will be what's coming up in the next year. So for example, I don't recommend the high school senior targets going off of their medication the summer before their freshman year of college, because it's such a big change and transition and an opportunity for some of those symptoms to worsen for a period of time. There is a black box warning around, suicidal thoughts, which is a very serious warning. And we always talk about that with families, so that there may be this subset of kids who experiences an increase in thoughts while on medicines. Does not mean that there are more completions on these medications. We know when we look at really big groups of patients, including kids, that the benefits can be very significant, but we want to watch for that side effect and then address it immediately. So I think that got to all those different pieces, Kara, but let me know if it didn't.
Oh, that was great. Thank you so much. And actually, just to make sure folks understand this idea of when you're looking for, or asking about suicidal thoughts, that's part of the ongoing therapies to ask the kid if they've been experiencing that, and also to help families suicide proof their houses if they need to during that time when they're adjusting, right?
Yeah, so we always think about prevention and how to make our environment safer for someone who might be vulnerable. The flip side with anxiety and OCD is sometimes we take care of kids whose intrusive worries and thoughts are about that side effect. And that can be a really important one to understand carefully, and work very closely with their therapist in taking care of understanding it and thinking about why it's happening and how to respond to that. So
Right. Thank you so much. We've gotten some great audience questions already. Thank you for those who have submitted some. If you have a question and you're watching live, you can type it on the comment section of the platform you're watching on, or send us a private message through the Facebook page of Michigan Medicine. I'm going to try and combine a few of these questions that have come in, and it has to do with a question we were already going to be addressing, which is, anxiety and OCD happening in kids who also have autism, ADHD, developmental disabilities, eating disorders, depression. Are there, this idea of, can these therapies work in kids who have co-occurring disorders? And also, how do we know what's, as the question came in, asking about autistic rigidity versus OCD. So maybe let's talk about overlap between some of these other conditions. I don't know who'd like to go first.
I can jump in. We do know there's a lot of overlap. Oftentimes, it is more common to see what we call comorbidity, or more than one diagnosis at a time rather than one alone. That sort of one single diagnosis presentation is maybe more rare, at least in our practice. So yeah, it's very common for various concerns to be happening at the same time. And there's nothing that prevents someone who has autism from also having anxiety, right? We are all equally vulnerable to anxiety. It can be difficult sometimes to tease apart, though, whether something is both anxiety and, let's say, autism in this example, or it's just one. And that can be somewhat tricky to tease apart. And so a good, careful diagnostic assessment is needed in those times. But sometimes it is truly both. And a lot of the time, our treatments are very effective. And really, it's a matter. So you mentioned eating disorders, things like that, very commonly comorbid or co-occurring with things like OCD or anxiety, very much. And when we want to decide what we're going to target first, I think that's the big question. So if someone has an eating disorder and it's really significantly impairing, they're at an unhealthy body weight or have other, health concerns, we're going to probably recommend that they treat that first. And then some of that treatment may generalize because there's a lot of principles, at least of the psychotherapy, that underlie a lot of the treatments we do. But it may not perfectly generalize, and then they may end up in treatment for anxiety. There's been a lot of research studies on how treatments for anxiety, the CBT, the exposure, work for autistic populations. And sometimes there needs to be a little bit of adjustment, but generally they work well. So I would say that, that is a time where it's really important to have a clinician you trust on board and talk through these questions of pulling things apart and which treatment we're going to target first.
From the standpoint of, the role of someone like me who might be part of the conversation around diagnosis and then medical treatment or medications, sometimes we don't know. And like Dr. Billick said, for example, if someone is concerned about ADHD or has that diagnosis, and then we see some signs of anxiety, treating one can help us understand the other better. So maybe that child, after they're on an effective stimulant medication for their ADHD, we're able to understand their anxiety symptoms better because that is less of an issue and less pronounced. So, that is the art and the joy of what we do professionally is this mixed picture that's so often there, but we can't always, use the crystal ball and know exactly what we're going to do as step one. And so it's just doing that in sort of a systematic way helps us understand that overlap.
Great. We also had somebody who mentioned oppositional defiant disorder, and also people just worrying that their child won't be receptive to treatment. How do you overcome that?
That's a great question. It can be really difficult to engage a child in treatment, and it's hard to answer that question specifically, but my general approach when it is challenging to engage a child in treatment is to really focus on building rapport with that child. Consider developing some type of behavioral system around engagement and treatment. And I often rely heavily on working with parents. Especially for younger children, parents are the agent of change. And we can oftentimes, when the child has difficulty engaging in treatment, we can still see a really great response to treatment through working even primarily with the parents. So we can kind of like adapt and be flexible in how we deliver the intervention when difficulties arise.
That's a really good point. I know I've heard that there's this idea of accommodating behaviors that families engage in and sort of accommodating the anxiety, the thing that's the source of the anxiety by maybe picking them up early from school or not going near dogs at the park or whatever it is. And so are there things like you talked about coaching the parents, basically? Is there a specific kind of coaching the parents can get to help them navigate this, especially given the shortage of providers like you who are, short supply, especially in more rural areas? That they have to do things more on their own as a family with guidance from a professional.
Yeah, I mean, we offer some really great programs here, often virtually. We have our parent management training clinic. We have a supportive parenting for anxious child emotions clinic, where we primarily do work with parents. The accommodation piece with parents is really, really tricky. As a parent, it's so hard to see your child in distress, and it's hard to see your child experiencing really difficult emotions. And a parental instinct is, I want to take that away from them. I don't want them to experience that. And in working with the parents, we can kind of develop some awareness around kind of like what's happening before this behavioral difficulty or anxiety difficulty, what's kind of happening afterwards, how am I responding to this, and how can I maybe like tweak or modify my response to address this concern. But it's tricky, and I think that many parents can benefit from working with a professional to kind of talk out these concerns and identify new ways of responding.
And that comes into play when, a child has or a teen has a cell phone and they're texting their parent from a situation that's making them anxious and saying, come get me, I can't be here. And so that I'm assuming is something you work on as well.
Absolutely. Yes. Yeah, plenty of children that the accessibility to parents has really increased. And as a parent, it can be so difficult. It's like my child is texting me, they're so distressed. What do I do? How do I handle this? It's really, really tough. So developing a plan for how I'm going to address these situations to show my child, maybe, obviously we're not talking about a specific child, but to show my child that they're capable of managing these difficult emotions. They're capable of staying in these situations. I validate and recognize that you're having a tough time, and I know that you got this. I know that you can get through whatever you're going through. Yeah, that's a huge piece of treatment.
Excellent. We had a question. Yeah, go ahead, please.
Just very briefly, I think, when we hear that word oppositional, a lot of us are really just trying to understand context and what's behind that. And it may be anxiety and helping the kid just understand how it's actually impacting their lives to get engagement, but it also might be understanding what else is going on for that child at school. What are the cultural factors for that family system? Are they marginalized in some way within their community that's making it hard for them to feel like they can express these things openly and it comes out in this aggression or other ways? So it's just a really complicated set of descriptors when we're talking about things clinically.
Great. And we've had questions from folks asking, could they have a link to some of these resources online? Are there national associations or state associations that we can steer people to, like organizations that are offering things or can send people, get people access to a provider that can help their child?
Yeah, absolutely. So there's two websites that I would recommend first and foremost. So one is ADAA.org, and that stands for Anxiety and Depression Association of America. They have lots of resources and blog articles. They often have free webinars, and they do have a Find a Therapist function on their website. So that can be helpful. That's ADAA.org. And the other one for OCD specifically is IOCDF.org, which is the International OCD Foundation. And it really is going to give a lot more information about OCD, about treatment, and also just like connecting families who are struggling both as parents or as individuals. So I would think those would be my two first stop shops because they both endorse evidence-based treatment. These are things that we know from the literature are the most effective treatments that we have right now.
Fantastic. Thank you so much. We also had a question come in about TMS or transcranial magnetic stimulation. Do we have evidence of that working? Is it allowed? Is it approved for people under 18? Dr. Quigley?
Yes, that's a great question and a rapidly changing landscape. So we do not have good data right now to say that we could recommend TMS for OCD and anxiety at younger ages, but the approval age continues to go down for TMS when it comes to depression. And I think that we are going to see a lot more come out from clinical trials and the research in the next few years. So hopefully we will have additional options for kids who are dealing with pretty refractory illness.
Fantastic. Thank you so much. We haven't really talked about school-based issues. Kids who have mental health conditions, parents may not realize that schools, public schools at least, are required to offer supportive services or plans to help accommodate in ways that they might need, not accommodations as in the less helpful ones, but things that will help the child attend school. And I know school avoidance is a big part of this. So let's talk briefly about 504s and IEPs for those who might not be familiar.
Yeah, it's a great point. And Kara, I'm just going to jump on something that you said, the accommodation piece. So it's tricky when we come to youth with anxiety, because you are right that there are a lot of barriers and there are a lot of stimuli at school. There's a lot of things that can make kids nervous at school. And sometimes it can be prohibitive to them making it to school, or they make it, but they're not participating or turning in their homework. And when that level of impairment is there, yes, it's really important to be working with a professional, but it can also be really helpful to be working with the school to get something like a 504 plan, which can help. It's focused on emotional impairment, I think is the words that they use. And it can help get the child back engaged in what they've been doing. So a 504 plan will look probably different for any child, but it really is focused on identifying accommodations in the school that could allow the child to participate, whether that is that they can give presentations, but not in front of a group, just to their teacher alone, whether it is that they can step outside from the classroom when they need to go to the counselor's office, take tests, in a private environment, or be in the front row. There are a lot of different accommodations, and they won't all be appropriate for every child. It's going to be a part of a treatment plan. But the point that I want to make here is that actually those type of accommodations can become unhelpful accommodations, right? What we ultimately want, as Dr. Boland pointed out, what we ultimately want is a child to be fully engaged with their lives and be able to be fulfilled and do the meaningful things. And so if we build in a 504 plan that pulls them out of things that are anxiety provoking for them without a plan of reintroducing it, it can get them stalled or even start to send that message again, like you can't do it. So when I work with families who want to pursue a 504 plan, or sometimes I even suggest it myself, what I am encouraging is that it is part of a treatment plan that has steps towards reducing those accommodations over time. So we don't think that it'll be helpful for the child to never learn how to give a presentation in front of a group, but we might have to start there so that we can work our way up.
Excellent. Thank you so much. We're getting toward the end of our hour, so I wanted to give all of our experts a chance to have any closing thoughts or remarks, things that you are hoping or seeing that research is going to perhaps make a difference in diagnosis or treatment. What are the mysteries still to be solved on these conditions? So anything you'd like to address, I'll start with you, Dr. Boland.
Yeah, I think just in closing, the main message that I want to impart is that there's really effective treatments for anxiety disorders. There's still so much that we don't know, but we do have these really great evidence-based interventions that can really be game changers for children and family. And I would encourage anyone, if you have concerns, seek out these evidence-based interventions, seek out support. There are resources available. So long ways to go, but we really do have some really great interventions for anxiety.
Great. Dr. Quigley, do you want to go next?
Thanks, everybody, and thanks everybody for joining today. And I think you've received a lot of information today. I would not underestimate the power of modeling as caregivers, as adults in the lives of kids and teenagers in terms of showing them how you manage stress or your own anxiety in a healthier way. Maybe talk about, what you notice about their lives and the skills that they have and the things that they do really well, because that can help, in their confidence in managing these challenges. And then if you are somebody who has engaged with care or treatment, or something about what that might be like for that child, to just help them feel like it's something like going to see, the physical therapist or any other kind of care provider, that it's just part of taking care of themselves.
And Dr. Billick, you get the last word.
Yeah, I mean, I echo a lot of what my colleagues have said. I think the other thing that comes to mind that can be such a frustration for families is that access to care is really limited. And we know that we are woefully understaffed in terms of child and adolescent psychiatrists, in terms of therapists who are trained in evidence-based treatment, and that can be so frustrating. So I just want to acknowledge that if that's something that you have dealt with, getting access to someone who you trust or is a good fit for your family, you're not alone. They're not any really obvious one solution to that right now. We do a lot of work to try to increase access to these skills in schools or through other avenues. And there are books out there, so you can look for books and workbooks that focus on exposure and response prevention or CBT, and a lot of those are quite good. But if you are feeling the fire in your belly, I really encourage you to advocate, reach out to your local representative, talk about parity in mental health, a big struggle. The reason we don't have enough providers in this field is that insurance doesn't really pay at a rate that is going to be, competitive for many people. So that's, I guess, my soapbox is we need more providers and we need the systems to change in order for more people to go into this line of work.
Thank you so much for spotlighting. This is a national issue, both the lack of providers, the shortage of providers, and this increase in kids and teens who are going through this. So I really appreciate that we ended on that note. And that's why we're doing this live stream and other mental health month events as well. We will be summarizing this talk also in an article that will appear on the Michigan Medicine website soon. And hopefully people will be able to access and share that. We'll have those links to those resources you mentioned and other resources. And if anyone is looking to give us feedback on today's event or join the email list for more information from U of M about mental health topics, there'll be, I believe, a comment on the platform that you're watching on to get to that. But no matter what, we really appreciate all three of you spending this time. We appreciate our audience. Some great questions today. Thank you so much. And we really hope you'll share this beyond your own community. Everyone needs to know that this is something that's affecting a lot of kids and teens, and that there is help available, and there is hope. So thank you so much to all of you.